Wonderful. So, hi, everyone. I'm Dr. Helly Goez, and Dr. Hollis will, as you see here too, we will co-present the Creating Connections Between Community and Curriculum, the discuss model. We are acknowledging the contribution, collaboration, and inspiration from Dr. Tracey Hillier, who was our Associate Dean, Undergraduate Medical Education, who is in the audience here. And without leadership support, nothing would have happened. Dr. Joanne Rodger, who is also in our audience, that took part in the compilation and analysis, and Dr. Brett-MacLean, who helped us putting some things together and inspired us in a few directions. So welcome, everyone. And thank you, Hollis, for joining me.
All right. So this project really has to do with how we engage the community in order to enhance our curriculum on topics related to social accountability. For those of you that like reading some of the definitions, here is the, I believe this is the WHO's definition for social accountability. Part of the reason why we engaged in this project was we wanted to make sure we integrate some of the we wanted to integrate the socially accountable content into our curriculum because we recognize that there's an increasing volume of information on social responsiveness and accountability, and that there is an increasing demand for medical education to address such topics. But also recognizing that we need to reflect on the immediate needs of the profession and adapting to the knowledge that's relevant to the practice. So in a medical school, it really is a diverse set of topics that needs to be covered across a wide range of information. So rather than engaging with the medical stakeholders to deliver in this type of content, we engage with our community in order to discuss some of these topics. In creating these, the new program that we're going to describe to you, Helly's going to describe to you today, what our program really was building on is the academic service learning components, where in the initial states, we required students to complete a 20-hour volunteer commitment to community service. And through the relationships that's established with the variety of nonprofit and community agencies, then we fostered the commitment to social responsibility, and then we were able to better engage the various stakeholders to participate with in collaboration with the development of our curriculum and to provide experiences for our learners, to support immigrants and refugees, people with addictions, and other parts of our community members. So you may wonder, why is this important and why are we talking to you about this? It's because one of the biggest challenge in integrating new content into a medical school curriculum really has to do with how a medical curriculum is assembled. It's a mosaic that is composed of different specialties, different type of specialists, provide a segmented approach towards each piece of the curriculum, and all of them basically places a structure and provides barriers to change because of the complexity of how we deliver the medical content based on the variety of expertise. So for example, we have at the University of Alberta, we have about 650 medical students, and it's being delivered by over 1,000 faculty members that are either doing clinical preceptorship or at the small group learning. And there's over 10,000 hours of planning each year into all of their learning experiences across the 4 years of their programs. So any change to this curriculum really requires an alignment from availability of faculty to teach them, availability of content, as well as resource and timing. So in trying to address this, we came up with the discuss model.
So this is a 5-step approach, and you can see below the link to the publication. D stands for the big D, the diversity. And the steps are the identification of gaps, which includes steps like raising questions, curricular mapping. The first S is searching the literature, scoping, rapid reviews, for example. The big C is the creation with community engagement, which is a highlight of this model. The U is actually a silent U. It involves all of us together. Inclusion is critical, and it's not about us as faculty or staff or learners. It's all of us together. And then the S stands for sustainability, which is super important. It is taken from different models, starting from business school, ending in educational methodology in terms of ensuring relevance, assessment, and evaluation. And the last S, social accountability, is not merely a result of all this, but this is absolutely an active phase of periodical updates of the curriculum. So I'll walk you through briefly in the working example, which was the first theme that we started integrating. We started integrating the gender curriculum into the MD program, in the undergraduate medical education program. So the diversity piece of it, included the co-creation of a working group that was established with local LGBTQ2+ community members, diversity advocate that was proficient in gender, the appropriate gender terminology at the time. And they were part of the healthcare system, so both hats. Collaboration with the Faculty of Education and specifically members of the Institute of Sexual Minority Studies and Services, along with educational experts. One important thing to mention here, and across all the themes that we'll mention later on, is that it started with the leadership of a student that started in a summer studentship, and Hollis and I mentored throughout the years of the co-creation of this curriculum. So all this group reviewed the literature, and we mutually created objectives that focused on these 3 bullets that you can see here. Is the development and delivering the curriculum that reduces negative bias, which was a highlighted point in the literature review, the integration of a session that dealt with people's lived experience into the curriculum to foster empathy, positive attitudes, because we are grooming and helping these budding physicians to advocate and be meaningful in their sensitivity in their provision of health, and to develop an evaluation framework for this curriculum. In the identification of gaps, the search of the literature and the co-creation, these were informed by these objectives, and additional review of the literature led to the ideas of 2 new sessions. However, after the consultation with the broader team, ideas for another 3 sessions were identified and prioritized, particularly communication skills, community service, and patients' lived experience, that led to one of the sessions that we'll briefly describe, an open book session that was the first module that was introduced in year 2 in the MD program. And this open book session invited 25 local LGBTQ2+ individuals that were recruited through social media to participate in a half-day session with intimate groups of 3 to 4 medical students, where each volunteer shared a chapter in their living book on their lived experience in accessing and navigating healthcare systems.
So when it came down to making sure that the students were able to kind of take back into the experiences, we used something called the utility value intervention, which is a reflective essay in order to look at the experiences of the open book session in order to determine how it was personally and professionally related to their own experiences. And this has been demonstrated in the literature for being able to increase their student learning and relating the materials back into their own lives. In order to sustain these type of participation events, it was important for us to provide a feedback mechanism and to sustain the sessions through soliciting questionnaires, as well as to our volunteer participants, students, as well as community stakeholders. So here is an example of some of the recurring themes that were identified throughout the narrative reflections. As you can see, that's for some of the themes here, there's a recognized need for open, the students have recognized that there's a need for open and safe healthcare environments, importance of patient-centered and empathic care, importance of using inclusive languages, and need to build relationship that fosters trust. Some of these themes that are kind of consistent throughout this conference. And this is how we were able to identify that in the evaluative outcomes, in looking at these themes that were identified, we're able to see that there's evidence for multiple positive impacts, both within the integrating and making community relevance into our curriculum, involving our community into our teaching and learning practices of the medical school, as well as the student acceptance into the types of learning that are being placed. And some of the more concrete types of evaluative outcomes that we were able to measure was that there was an increased score in the graduation questionnaire, which is a third-party administered questionnaire, as related to social accountability that indicates a preparedness, as well as the diverse and marginalized patient groups, since this type of approach, learning approaches have been introduced.
So we actually, based on this model, we had additional applications, as you can see here, in different themes of equity, diversity, and inclusion. And you can see them here, from global health, human trafficking, refugee health. At the bottom, you can see different names and times of publication. These are all students, our learners who were very immersed and very involved in different parts, whether the initiation, whether curricular mapping, took ownership, and also developed their scholarship skills. On the right upper part of this slide, you can see the publication itself. And additional outcomes are the expanding matrix of relationship with community organizations that did not start with this, but actually started way before we established the model, as Hollis previously described, with the academic service learning. And this was another foundational aspect of this work in the creation, the co-creation of relationship and fostering trust. Some of the sessions were taken to faculty development sessions such as the proper language and terminology for LGBTQ2+ groups, as well as refugee health, and other medical schools are currently adopting the model.
So I hope that we've demonstrated this approach towards how medical school curriculums can incorporate and invite the larger community in co-creating the relevant and medical curriculum that's needed inside the medical school. And I hope that our sharing has kind of demonstrated that this approach can be used and into sharing different topics, as well as we've demonstrated. And one of the key highlights here is that the discussed model can be flexibly adapted towards different needs of the diverse community groups. We're very thankful to have had the leadership supports, Dr. Hillier there, in allowing for this type of approach, to trial for this type of approach that's highly versatile and have allow for a community engaged approach towards creating the curriculum content. And this is our this is what we like to share. Thank you very much for your attention. Do you want to stop recording?